many more of the interdisciplinary team members in a way that I think is really going to improve care for the patients. One particular aspect of the PDPM is the function code, or the GG section of the MDS. It's not only vital, but it's going to be publicly reported on the Nursing Home Compare site. And this is a new section, and under PDPM, it's much more geared around the overall function of the patient and their level of independence with different activities of daily living. And the system for post-acute care providers is meant to reward the best outcomes for patients, not just the volume of care provided, but the actual patient outcomes. So let's talk about PDPM and sort of talk about an overview. The patient-driven payment model was implemented last fall, and it's a new reimbursement method for Medicare Part A patients, so skilled nursing facility patients. Currently, the long-term care patients are not affected by the PDPM changes. And like I said, the PDPM takes into account the patient's conditions and their medical diagnoses, specifically the medical diagnoses for which they were hospitalized, but also their underlying background medical problems as well. The focus is really on the patient and their family. It's a person-centered care, a much more sort of holistic view of the patient and their overall function. One thing that's really, really important for the success of PDPM is to appropriately identify valid, appropriate medical diagnoses, not just adding on medical diagnoses as you see fit, but really drilling down to the underlying medical problems that are necessitating the stay. Like I said before, it's an outcomes-driven model, not a volume or minutes provided type reimbursement system. Let's talk a little bit more about PDPM and what this actually means. The previous RUG system was based on reimbursement for minutes provided, primarily for therapy treatment. And PDPM is calculated differently. It's a pretty complex formula based on the individual patient characteristics as coded by the MDS. So identifying those characteristics and those diagnoses is really, really crucial to payment under the PDPM. We're moving away from the volume of care provided, the therapy minutes, and that's no longer the primary driver for reimbursement. The outcome of the patient is the primary motivator, although therapy is absolutely essential in PDPM as well. Function of the patient is key. The goal is to increase and maintain function of the patient in activities of daily living. And restorative nursing is also much more important under PDPM. That's a good thing because sometimes the restorative nursing in the past got dropped by the wayside when staffing needs were low. But this really drives home the importance of that aspect of care. And also PDPM includes much more of the complexity of the nursing care provided. So PDPM has a payment model system that recognizes that the majority of the cost to the nursing home provider of providing care, especially therapy care, is upfront. It's in the first 20 days or so of the patient's stay. And so physical therapy and occupational therapy are reimbursed most highly in the first 20 days of the patient's stay. Speech and language pathology is added into the mix. Nursing care, of course, is included as non-therapy ancillaries, and partial sickness, pressure injuries are included under that nursing rubric. The non-therapy ancillaries we'll talk about coming up here It includes a variety of wound types and full thickness pressure wounds, as well as wound infections and the risk for malnutrition. So some non-therapy add-ons, and I should say that non-therapy add-ons are a modifier, a point system modifier to add onto the baseline reimbursement under PDPM. And the number of points that are allotted for different medical conditions that the patient may have can increase the PDPM reimbursement. So some examples of non-therapy conditions that would add to the PDPM reimbursement in the wound sphere include stage 4 pressure ulcers, which add 1 non-therapy, severe skin burns or severe skin conditions, again 1, other foot skin problems, a foot infection code or other open lesions except for diabetic ulcers adds another NTA. A bona fide wound infection adds 2 NTAs, which recognizes that those wounds are more complex and require more care, and that's appropriate. Diabetic foot ulcers also add 1 NTA point. So how the NTA specifically relates to the potential relationship with wounds and wound care. NTA includes special treatments such as isolation or infection precautions, IV medications, trach care, transfusions, intermittent catheterization, feeding tubes, ostomy care. Those things all relate to wounds and may be nursing related. Also, NTA accounts for special costs associated with HIV and AIDS care. So the diagnosis related to wounds is really, really important. We want to make sure that we get the correct medical diagnosis for different types of wounds. As we talked about, diabetic care and diabetes are a separate medical diagnosis that adds to the complexity of the care of the patient. Wound infections and infections particularly not related to the foot, and malnutrition or risk for malnutrition, of course, impacts wound care and wound healing. But the malnutrition needs to be an actual diagnosis and not just, well, you know, she's not eating well in the past 3 days, and so we're just going to add that on there. You need to have some evidence of malnutrition. And of course, we want to follow the resident assessment instrument rules and guidelines. So let's look at a little bit more at PDPM and post-acute care. As we talked about earlier, reimbursement changes only impact those patients who are on a Part A skilled stay, and highlighting, of course, the functional score of the patient. Under GG, section GG, it's a multidisciplinary code that receives input from the whole interdisciplinary team. And it really, I think, is a great thing because it makes everyone on the team feel like they have an important input into the care of the patient. It's not just nursing deciding or the provider deciding or therapy providing. It really relies on information derived from nursing assistants and other people in the post-acute care sphere. Of course, we're staying aligned with federal guidelines and expectations for all of long-term care, and also with person-centered care and best practices. So, vitally important to appropriately coding and being reimbursed under PDPM are knowing the primary cause of a wound. And this is an area that we as wound care providers can really impact and provide guidance and education to everyone in our facilities to help make this diagnosis correct. My experience in post-acute and long-term care is that often the wound care nurse or the wound care team understands wound classification, but often nursing doesn't. And sometimes there's not great communication with the MDS nurse. So, you know, the documentation may not match up between MDS and nursing and the wound care team. So there's an opportunity for us to provide more education to our nursing staff and also our CNAs, but also administration. It's good for us to all be on the same page. Not everyone is going to be a wound expert, but it's vitally important that all those other team members understand what we're working with. And it also allows them to provide better care. So the diagnosis and classification of wounds, especially at admission, are really vitally important. We want to make sure that we understand, and our nursing staff and other ancillaries understand the difference between venous and arterial ulcers versus diabetic or neuropathic ulcers, pressure injuries or pressure ulcers, burns, and other wound types. So if we do have a pressure wound, we want to make sure that we are staging correctly. And this has been an area of opportunity that I've seen in my practice in the last 15 or more years. We want to make sure that we're getting the stage correctly. There's, of course, a regulatory impact. If we're claiming wounds, that may be an area that, that the state surveyors are going to be looking at more closely, and they should. There, of course, is going to be a patient satisfaction impact having a pressure wound. And again, the functional score, the GG section is going to be impacted by diagnosing a pressure wound. Of course, we know that lack of mobility is one of the leading factors that can lead to pressure ulcers. So that's vitally important. Pressure wounds, of course, are at risk for infection. There may be an increased risk for hospitalization due to advanced stage pressure wounds. And we need to make sure that our facilities are having evidence-based guidelines in place and that we're following those. The entire care team needs to sort of have a consensus about what the correct stage is of the pressure ulcer or pressure injury. I think in the past there's been some incentive for facilities to not stage wounds correctly, to stage them lower than they might be, or stage them as deep tissue injuries in order to avoid having that flag on the MDS. And when I've done investigations in the buildings that are having problems with wounds, it's very clear that there has been a lot of confusion and lack of consistency across the interdisciplinary team about the actual stage of the wound. The team approach does offer benefits and risks of options, and we want to make sure that the patient and their family are at the center and driving the care for healing pressure wounds. Vitally important to PDPM because wound infections are important from the patient aspect and their ability to heal those wounds. It also impacts reimbursement. We want to make sure that we are recognizing and documenting wound infections. And we want to make sure that we understand the difference between a local wound infection and a systemic infection, both, again, for the care of the patient and for reimbursement purposes. So looking at the aspects of a local infection, we typically see a halo of erythema around the wound, and it's been present for a week or more. We often see an increase in drainage from the wound. We might see a friable base that bleeds easily when touched with a Q-tip. We might notice an odor that continues after we've cleansed the base of the wound. And we might see wounds that are having difficulty healing, either non-healing or slow healing. And these are wounds that we would expect to heal. Alternatively, systemic infections, some of the signs of those include increasing erythema, moving beyond the wound edge borders, increasing odor and drainage, but also increasing wound pain. That's often a crucial sign. Purulence or pus coming from the wound is often a sign of systemic infection, but is not diagnostic. The systemic infection signs also include fever, a feeling of malaise, an increased white blood cell count, and a change in functional status and or mental status. It's sometimes hard to differentiate between these, but hopefully these guidelines will help us. Within PDPM, we want to make sure that we are accurately identifying medical diagnoses and applying the appropriate codes. We want to make sure that we have the appropriate primary diagnosis codes and secondary codes, especially on admission. We want to make sure that we're using the ICD-10 manual to make sure that we're being accurate. We want to make sure that we're having appropriate wound assessments on admission and discharge, and anytime the patient is going out to the hospital. We want to make sure that the wounds are classified correctly and staged correctly. And we want to make sure that we're identifying true infections versus just colonization of wounds. And I'm sure we've all seen that sometimes things are called a wound infection when somebody has done a surface swab and sent that for culture, and we know that that's not accurate and is going to come back with a collection of bacteria that doesn't necessarily indicate that an antibiotic is warranted. We also want to make sure that we've got good, accurate documentation from our nursing staff and our nurse practitioner and physician providers to make sure that we're all on the same page and there's evidence that communication is occurring and that we're working well as a team. Having that documentation in place also helps support the PDPM codes that we're using for reimbursement. Also, the accuracy is really, really important to make sure that we're catching those nursing and non-therapy ancillary components of PDPM. So, as we talked about earlier, infections in a wound can really improve or increase the PDPM reimbursement. Wound infection, bona fide wound infection adds 2 NTA points, and if we have a multi-drug resistant organism, that adds an additional NTA point. So the good news is if we do have a patient with an infection and they have a multi-drug resistant organism, that the facility is being reimbursed appropriately for that care. So some considerations for patients with diabetic ulcers. As we talked about, the diabetic ulcer adds 1 NTA point, and we know that healing a diabetic wound is the most expensive wound type to heal in terms of time needed and care needed in order to optimize wound healing conditions. And we know that diabetic patients also have an array of other comorbidities besides wounds. We know that the nervous system is affected, the arterial system is affected, and many other things. Diabetic patients have a higher risk of infection for many different reasons, and infections and diabetic ulcers are one of the leading causes of amputation required in diabetic patients. So it's a good time, actually, this is a good point for us to look at how we're interacting with our licensed clinicians and really asking them, sitting down and having a conversation about how well we're doing with screening feet for skin issues on admission and during the patient's care. how often licensed clinicians are assessing sensation in diabetic patients or those with neuropathy, doing appropriate testing to make sure that we're identifying if we have sensation problems that can lead to diabetic ulcers. Also, we want to make sure that our patients with diabetes have appropriate footwear and not just, you know, well-fitting tennis shoes or slide-ons, but actual diabetic diabetic shoes, special care to make sure that we're optimizing conditions for healing that wound. We also know that the neuropathy that goes along with diabetes and other conditions impacts other aspects. Could probably increase the risk for pressure sores because they're not able to sense that they need to change position, and it probably increases the risk of falls as well. Balance is often affected, and the proprioceptive sensors in the feet and the lower extremities may cause an increased risk of falls. So I'm going to turn this over to Janine at this point. She's going to talk more about the practical implications of implementing PDPM in our practice. Janine?
So I'm going to take over here and share with you, so what has PDPM really changed for me, for all of us in post-acute care when it comes to wound management? So let's talk about first the resident and the patient impact. And it's important to keep in mind that the needs of the patient, our residents, they haven't changed. The intent here has changed. So with the structural change of PDPM, the intent is to improve quality care and, as Dr. Evans said, outcomes. I love this quote: "Every system is perfectly designed to get the results that it does." So keep in mind, back with rugs, the design was minutes, right? So our rugs were based on minutes. And so therefore that was our focus, and it almost divided us more into silos of practice. The system now needs to be designed with a team approach to really get those best outcomes. And I think that confuses people. A team approach doesn't mean that I, as a physical therapist, will now play the role of a nurse or a doctor. It means that we're all collaborating, that we're coordinating our care, that we're each bringing to the table top of the license practice to contribute and offer that resident, that patient, their family options for a pathway toward their goal. So important to keep in mind as we go forward here, I'm also not going to play the role of the patient. And too often we don't provide the patient, resident, family the benefits and the risk of proposed options to help them make their choices to set those goals. Too often, the goal that we all set is clearly just to get to healing, which is what we all want. But it may not be the most appropriate appropriate goal for that resident or patient or that family based on what it might take to get them to that point. So the outcome is based on what is best for the patient, driven by the patient. PPS focused on treatments, and boy, did we deliver. So we were really focused on it's a hole, and we need the special best Band-Aid or ointment, right? And hence now we have thousands to choose from, but our outcomes aren't really all that much better. Whereas PDPM focuses on quality outcomes, and the rest, hopefully, is soon going to be history. So let's talk a little bit about top of license practice. And as a PT, I recall coming out into long-term care more than 20 years ago, and I didn't learn what the nurse's role was in wound management in PT school, or the providers. So it's important to really sit back and reflect, what is the role of everybody on this team? And how do we all work in our own lane, but could the lanes be wider? Could we better collaborate to bring that resident and patient and family the best information. And so in the center, the nurse's role is often that facilitator of that team. And so it's the nurse that is with the resident, patient, family, more often than the other providers or therapists or dietitian. It is the nurse that's doing the dressing changes and will see firsthand when there's been any changes in that patient's wound. They're often the individual that's more often engaging with that patient on a daily basis. They're often the person who sees that person's skin, their resident skin on admission. So they need to be aware of the most common wound types. Now, as Dr. Evans pointed out, those wound types, that is a diagnosis. So although the nurse recognizes the common wound types, it's that conversation with the provider to get the right documentation and the right wound diagnosis for the patient and also for PDPM. It's also the nurse that is frequently doing treatments, and on the team, it's frequently the nurse that really owns what the guidelines or protocols might be in that facility. So they know exactly how to use those treatments based on the conditions of that patient's wound. Certainly, I have learned a lot from my nurse colleagues out in the field about a compassionate approach to wound management. And frequently it is the nurse that is providing oversight and direction for the restorative nursing program. And as we heard from Dr. Evans, the provider's role is essential here. And there are still some centers, some nursing homes that still continue to focus on wounds as a nurse problem. It is not a nurse problem. It is an opportunity for the entire team to really engage with that resident to offer not only patient-centered care, but patient-driven care. It is the provider that can provide us the wound diagnosis ICD code. It's also that provider that's going to help inform the entire team, including the resident and family, what are those comorbid conditions that could impact healability? What are those comorbid conditions that could even, in fact, prevent healing altogether or require a surgical intervention? Often, it's the provider's role to engage in those really difficult conversations about advanced care planning. Perhaps healing the wound is not the goal, but comfort or palliative goals are more appropriate. Certainly, we want the provider to be a leader with antibiotic stewardship. So as we heard early on in this presentation, know what the signs of infection are, because we certainly do not difficult conversations about advanced care planning. Perhaps healing the wound is not.
Hello, today we will be talking about
are more appropriate.
Their metabolic
we want the provider
factors,
to be a leader with antibiotic stewardship.
bipolar disorder,
so as we heard early on in this presentation, know what the signs of infection
metabolic
are,
disturbance,
because we certainly do not difficult conversations about advanced care planning. Perhaps healing the wound is not.
Hello, today we will be talking about
are more appropriate.
Their metabolic
we want the provider
factors,
to be a leader with antibiotic stewardship.
bipolar disorder,
so as we heard early on in this presentation, know what the signs of infection
metabolic
are,
disturbance,
because we
And now we will go into the live Q&A. We're at 22% right now. Nope. I think it took more from the videos, which makes sense.
I'm Mary Evans. I'm the National Medical Director for Golden Living, and I'm here today with Jeanine McGuire, who's the VP of Skin Integrity and Wound Management for Genesis Healthcare. We'll be talking today about PDPM and how it impacts our practices. First, we'll talk about the learning objectives for this session. We're going to talk a little bit about the financial results of PDPM. We're going to talk about how PDPM has shaped nursing practice, therapy practice, and most importantly, our patients and residents and their families. And then finally, we're going to talk about how we can survive and thrive in this new atmosphere and some specific strategies for that. So what's changed with PDPM, or the patient-driven payment model? Prior to last fall, we had a pay for prospective payment system that the revenue was based on the number of therapy minutes provided. And wounds didn't particularly increase the payment to post-acute providers. And the approach to care was kind of fragmented. There was some siloing of nursing, therapy, things like that. And so perhaps the care was not the best organized or provided. And that system had been going on for several years, and it was really, the end result was that care and the payment for care depended on a high number of minutes of therapy provided. And there were some problems with that, and CMS recognized that there was a drive to provide therapy minutes at times that might not have been appropriate. And so PDPM was developed in a way to sort of rein in costs and look at the whole patient and change the payment model to one based on the patient's needs and a more holistic approach. So the patient-driven payment model is revenue based on the patient's needs, particularly based on their diagnosis and therapy needs. In this system, wounds are now recognized as part of the payment model, and it's very important to prevent and heal wounds, and this impacts the economics of the payment system. Under PDPM, the team approach to care is really vital, and it helps incorporate many more of the interdisciplinary team members in a way that I think is really going to improve care for the patients. One particular aspect of the PDPM is the function code, or the GG section of the MDS. It's not only vital, but it's going to be publicly reported on the Nursing Home Compare site. And this is a new section, and under PDPM, it's much more geared around the overall function of the patient and their level of independence with different activities in daily living. And the system for post-acute care providers is meant to reward the best outcomes for patients, not just the volume of care provided, but the actual patient outcomes. So let's talk about PDPM and sort of talk about an overview. The patient-driven payment model was implemented last fall, and it's a new reimbursement method for Medicare Part A patients, so skilled nursing facility patients. Currently, the long-term care patients are not affected by the PDPM changes. And like I said, the PDPM takes into account the patient's conditions and their medical diagnoses, specifically the medical diagnoses for which they were hospitalized, but also their underlying background medical problems as well. The focus is really on the patient and their family. It's a person-centered care, a much more sort of holistic view of the patient and their overall function. One thing that's really important for the success of PDPM is to appropriately identify valid, appropriate medical diagnoses, not just adding on medical diagnoses as you see fit, but really drilling down to the underlying medical problems that are necessitating the stay. Like I said before, it's an outcomes-driven model, not a volume or minutes provided type reimbursement system. Let's talk a little bit more about PDPM and what this actually means. The previous RUG system was based on minutes, and that's no longer the primary driver for reimbursement. The outcome of the patient is the primary motivator, although therapy is absolutely essential in PDPM as well. Function of the patient is key. The goal is to increase and maintain function of the patient in activities of daily living. And restorative nursing is also much more important under PDPM. That's a good thing because sometimes the restorative nursing in the past got dropped by the wayside when staffing needs were low. But this really drives home the importance of that aspect of care. And also PDPM includes much more of the complexity of the nursing care.
Hello, everyone. My name is Lori McNichol, and thank you for joining me today. The title of this presentation is Patient-Driven Groupings Model, or PDGM, and the Impact on Home Health. The first thing I would say is that there is so much to say here and so little time. But here's the outline of today's program. I would like to review briefly the previous PPS payment model. I think that perhaps you are well familiar with that. It has been around for 20 years. I would like to summarize the changes with PDGM, have us consider the financial impacts, discuss changes in our clinical practice in home care, maybe share a few strategies to survive and most importantly, thrive in this new environment, and finally, to celebrate best practices and a few success stories. By now, if you work in home care, you have been involved in the transition from PPS to PDGM. It has clearly been touted by many who work in our care setting that it was time for a change, but like most aspects of our life, whenever we have change brought upon us, it does create a prime environment for a little bit of stress in transition. To briefly overview the prospective payment system, it is important to remember that it has been around, as I said, for 20 years. First implemented in October of 2000, it bundled the payment for all services provided for a 60-day episode of care. All agencies were required to submit one request for anticipated payment, kind of a prediction on what we would expect to be paid for that 60-day episode. And there was a split percentage payment, 60-40, 60 in the first episode, followed by a 50-50 payment for all subsequent episodes. As you know, the outcome and assessment information set, our friend OASIS, was completed for every patient. The amount of payment was determined by the case mix adjustment, originating from one of 153 HHRGs, or Home Health Resource Groups. 153. They were based on 3 severity levels: clinical, functional, and service utilization. And the service utilization was based on the number of therapy visits per episode. Now that caused a potential for some bad players to game the system and to gain financially, trying to beef up the service utilization numbers with therapy visits. Low utilization payment adjustments, or LUPAs, those were the ones made with 4 or fewer visits per episode. What was CMS's motivation for change? Well, there were really 3. PPS resulted in a lower reimbursement for patients with clinical conditions, resulting in an increased need for nursing care. I am a nurse in home care, and we saw right away that it didn't seem fair that our patients with many clinical needs that required high frequencies of nursing visits and complex patient teaching, really, we weren't seeing the reimbursement for those services. We realized, and CMS realized, that payment should not really be based on the number of therapy visits, and that patient characteristics should determine payment overall. The PDGM model, or the patient-driven groupings model, has been touted as the best thing to happen to home care since sliced bread. This really puts the reimbursement in the agency's hands that are delivering the most complex clinical care, and that really seems to make sense, doesn't it? This is a great table, and I thought that we could spend a few minutes teasing this out because there are just 5 main case mix variables in PDGM. One is the admission source, and you'll see that there is community admission source and institutional admission source. Those are further broken down to be early and late in each one of those categories. There's also a timing, and that's that early-late. We know that if someone comes to us early and from after an institutional diagnosis or much later after discharge from an institutional care setting, that it makes quite a bit of difference in how much clinical care they will be needing in the home. In terms of clinical groupings, you remember there were 153 and now considerably fewer. We'll take a look at neuro rehab, wounds, complex nursing interventions, MS rehab, behavioral health, and so on and so forth in this orange category, orange part of the table. Of particular interest to those listening in on this webinar will be the wounds category. When we discuss the comorbidity adjustments and the clinical groupings, I'd ask you to take a look at functional impairment. This comes directly from the OASIS items and will be low, medium, or high. But the comorbidity adjustments come from secondary diagnoses reported on claims, and we'll take a look at that in my next slide. So again, the source of referral is imperative, community or institutional admission source, not always from an acute care facility or hospital, many times from an LTAC or from a skilled nursing facility. Here is another thing that we have to pay attention to, the 30-day payment periods instead of 60-day payment periods. 12 clinical subgroups, only 3 functional impairment subgroups with 3 comorbidity adjustment subgroups. This results in 432 case mix groups, with each group defining their LUPA range from 2 to 6 visits. The therapy threshold, and I think if I could highlight any slide here, any bullet here, it would be that the therapy thresholds have been eliminated. Here's what the PDGM clinical and functional groups currently look like. We've got our clinical groups in the red header table, and let's scroll down to wounds, post-op wound aftercare and skin, non-surgical wound care. The primary reason for home health encounter is to provide the assessment, treatment, and evaluation of surgical wounds, the assessment, treatment, and evaluation of non-surgical wounds, ulcers, burns, and other lesions. Then we would need to see how this impacts on the patient's functional scores, on grooming, the ability to dress upper and lower body safely, toilet transfers, bathing, and so on and so forth. But for every diagnosis, for every clinical group and comorbid condition, you would see how this can be calculated to determine our patient's needs in home care. What will that mean for us in terms of financial impacts? Well, the first thing, the payment is based on where the referral originates. Now, that means a lot to us. It has always been important that patients are received into the home health care setting when they are actualizing their biggest need. But it does give a provision. So if a patient has been home for 10 days and they realize that they're unable to function. In my practice, I have seen patients who have family members who are with them immediately after a hospital discharge or a discharge from a long-term acute care facility, only to find out that after that family member returns home, the patient is unable to be maintained without the services of a home health agency. So we pay attention to where our referral originates. This billing cycle going from one 60-day period to every 30 days may result in the need for additional FTEs for the home health agency, certainly in the billing and coding department. The split percentage payment is going to evolve into 20% on RAP and 80% on the final claim. And this is going to require home health agencies to budget differently. They're going to have to think about the patients that they're taking in and when they'll actually be seeing a remuneration and reimbursement for those services. This is a little caveat that newly enrolled home health providers on or before January 1st of 19 will not be receiving that split payment, the 20% on RAP and 80% on final claim. They will be getting the entire payment made with the final claim. I would say at this point, the LUPA thresholds are not well understood, and we will have to wait and see how that evolves. But it is something for us to project that there may be some losses in that area. I would say that always ICD-10 coding has been important and accuracy has been imperative, but even more so now because we must avoid the rejection of claims. When we see this payment model, we are incentivized to get it right early in the billing cycle. And as I've already alluded, that agencies that have heavy therapy caseloads are going to receive less payment than they had been receiving under the PPS model. So, do we anticipate changes in clinical practice? I think that we would all agree that we will see significant changes here in clinical practice. In theory, there shouldn't be a change. The therapy needs could decline and the nursing needs could increase. However, the National Association for Home Care and Hospice, or NAHC, revealed that 25% of providers reported that they would be reducing their therapy utilization by more than 10% in 2020. So we should always have been taking care of our patients with the services that they required, but it is interesting that we may see a decrease in therapy utilization now that therapy is not going to be reimbursed at the levels that it was previously. Another exciting, I think, change in clinical practice to our audience is that agencies not having expertise in providing acute nursing care in the home for wound care and infusion therapy, for example, really should beef up their infusion and wound care programs, because reimbursement is finally going to recognize the level of expertise in these two areas. And I find that often infusion therapy and wound care go hand in hand, not always, but often. Some opportunities here for those of us who practice in wound care. It is a great opportunity to make sure that all of our skilled nurses, all of our field nurses have improved skills in wound care. I think this is a great opportunity for someone to go into an agency and say that they will provide wound care education and one-on-one mentoring perhaps implementing a telemedicine program for wound care where people can monitor via photography or other technology, Zoom technology, for example, how people are progressing with their wounds. For years, people have said, gosh, this is a very costly patient population, and we didn't really see the remuneration for services. And perhaps now that that is more in alignment, our patients from the hospital, these complex patients, will be able to find themselves in home, because after all, that's where they would most wish to be treated. We'll be reimbursed for supplies, for expertise, and for the technology that's required to take care of these patients in their homes. And let us not forget patient outcomes. All outcomes will continue to be incorporated into Home Health Compare under Quality of Patient Care star ratings. High quality therapy services will attribute to better outcomes. And we see this, and we've known this in the past, but if your wound care program becomes the stellar program in your community, then you will become a referral magnet for this type of patient population. And with higher reimbursement than previously realized, it could be seen as a profitable arm to your agency. In just about every wound care lecture, you will hear that it takes a team, and it's all about teamwork. But we would agree that the complex patient requires a lot of care at home and a lot of support, because after all, these are the same patients that used to be hospitalized, and now they are in the home care arena. We should continue to show how important we are in home care as part of the cycle of care. At another lecture in this conference, you might have heard Dr. Janice Bites and I talk about transitions of care. And transitions of care have to be a two-way street. If a hospital or LTAC or skilled nursing facility is working hard to coordinate a smooth transition to the home, we really need to step up in home care and provide these same reassurances to our referral sources that we are the right agency to receive this patient, that our nurses have received updated and specialized training in wound care, and that we will be able to carry the patient to the next threshold, that is independence, if they are able to achieve that status. So it's up to all of us in home care to make sure that we are reinforcing to others in the community that we are a vital, competent team member. We have a couple of tips for how to survive PDGM, and I put it as a little first aid kit, but a few things to put in your suitcase. Some of the best advice I've heard in the past 5 months is that it's even more important now than ever to stay connected with industry experts and to stay up to date on regulatory changes. There are plenty of websites for us to visit. ACHC is a site that I frequent a lot, but there are other sites where we can go to make sure that we are listening to webinars and taking advantage of any newsletters that we maybe would have missed to keep us up to date on any regulatory changes. We want to be sure that our referrals come with complete information for accurate coding to occur. You see how important that first episode of care, those first 30 days are. So if we have to ask good questions in transitions of care, we want to make sure that we're asking about what the patient's abilities are, what have they been taught, where are we going to be catching that referral, and to make sure that we're familiar with supplies and the frequency with which wound care has to be performed, and to make sure that we're ready to receive our patient. and finally, to evaluate our billing and coding workflows. In the first couple of weeks of our changes, it's important to remember that coders are getting this kind of information, but anything you can help them. For example, standardizing the way you're going to document, making sure that you are staging pressure injuries, that you communicate with the coders to let them know when there is, say, for example, medical adhesive-related skin injury, and how helpful it would be if you indicate in your documentation in the EMR that it's a partial thickness or a full thickness wound. It really helps them to code accurately, which is important to the overall financial health of your home health agency. One of the things I have offered is for our coders to call me anytime they have a question. Even if they leave a message, I always call them back because we are learning each other's styles of communication, and we both know how important this billing and coding workflow is. Another thing that we should be is open to the potential of mergers and acquisitions due to cash flow issues. I think that these two words, mergers and acquisitions, tend to impart a feeling of uneasiness and stress. But if you find that your agency is either going to be merging with a new company or being acquired by another company, it's important to understand your role, your positive outlook, and the knowledge that perhaps someone might have been doing it better than you were in the past, and that the very survival of our industry and your particular agency may require a merger or an acquisition. So do your best to make those transitions as easy and as positive for your coworkers. Following changes to PPS in 2000, 25 to 30% of existing agencies went out of business. No one is saying that we're going to see those kinds of numbers as a result of PDGM. In fact, we think that this is a more accurate alignment of reimbursement and care delivery models. But stay positive, and there is certainly strength in numbers. I would encourage you to consider using telehealth to eliminate the need for some visits. We are proving this in many arenas, and certainly in light of the COVID-19 challenges, even those who might have been saying it can't be done are learning that not only it can be done, but it can be done without negatively impacting patient care. Even though telehealth right now is not reimbursed under PDGM, it could be a way to be more cost-effective in our delivery of care. We have several people who are reporting. I've seen a couple of poster presentations, but I am encouraged by this. And it may turn out that this is one of the good things that has come out of our COVID-19 pandemic, that we have all taken a closer look at telehealth and how it can be used in each one of our care settings, particularly home care. Care management collaboration between all clinicians caring for patients. This has always been a value, but it's perhaps never been more important. We do try to coordinate with our resources for physical therapy and medical social work, also trying to connect our patients to certified diabetic educators and also to registered dietitians. Some of you may roll your eyes if I speak to the individualized plan of care, but again, it has never been more important. We must show evidence of this. It cannot be a cookie cutter model, and our patients deserve a close look at their individual needs, and there is no better person to do that than the home care provider. Finally, I would say that we can create our process improvement plans that assist us with cost reductions without putting our patients at risk. We have always been exposed to lean models of care and to challenge to eliminate redundancies in care. And I think that now is the time to really protect our industry in home care and use some of these models. It's important to monitor reporting metrics that are critical to reimbursement. That may not be your role in your agency, or it could be, but we're always looking for trends and patterns and working with the diagnostic codes that are coming our way, who are our main referral sources, and making sure that those who are the liaisons to those practices and to those facilities are able to tout your great outcomes. We want to make sure that they know that if you have implemented a wound training program and 80% of your nurses have completed a wound training program, complete with demonstration of clinical competencies, that that is something that your liaisons are taking back to your agencies and letting people know that your agency will deliver better outcomes than perhaps any of the competitors. Keep a close eye on the timing of episodes, and again, monitoring functional status. It previously had a much higher reimbursement, but if we are reducing therapy visits, we do want to make sure that our patients are able to excel in their functional abilities. And to reiterate, continue to monitor your outcomes for home health care. I'm a big celebrator of best practice and successes, and I would encourage you to help your peers weather these changes by celebrating their successes and best practice. Stay up to date regarding your payment regulations and the trends of not only global and national agencies, but your neighborhood agencies. Make your patient needs a priority. If we take good care of our patients and provide the services that they require as identified by their individualized plan of care, we will achieve great outcomes. Give your staff the tools they need to provide excellent care, the products that they need to ensure good outcomes for wound care. Make sure that you keep an eye on your formulary and that they have access to the product categories and that they're familiar with reassessing wounds that are not progressing in a timely manner, and that they can access what they need, whether it be a referral or a different dressing or care modality. If they can access what they need, that they will be able to move the patients along the care trajectory. And share success stories to encourage colleagues. I'm always looking to see publications, poster presentations coming from our home health agencies. So in summary today, I'd like to remind you that Medicare Home Health has endured many changes since its inception in 1965, and we will survive the PDGM changes. We have to lead with flexibility, and endurance and positive attitude is really more important now than ever. Try to stay open to change within your organization. You will see new faces, new personnel, and perhaps even new business partners. Collaborating with all of the clinical experts at other disciplines to determine best practice will result in positive outcomes. And last but not least, if we make our patient needs a priority by providing the best care available, the dollars will follow. We were all asked to add a slide for what have we learned in the COVID-19 pandemic, and here were a few things that I thought I would add. Patients and their families fall into two categories, frightened or laissez-faire, and both ends of that spectrum require education. I have noticed that home health care providers are just as frightened about contracting COVID-19 as everyone else in healthcare. And overwhelmingly, many have told me that they feel uncelebrated as essential workers. You know, we work in a different environment, and those who work in home care who are listening in today know that perhaps we didn't walk into the office over chalk-colored sidewalks that said thank you. But we do thank you. People in hospitals have said that, you know, they were the essential workers, but so many of our home care providers didn't actually get that pat on the back, that little boost that they maybe felt that they needed. And I regret that, and I wish that I could gather them all up. And maybe if you're listening today, I hope you hear how much I appreciate everyone who works in a home health agency, because you are essential, and if you were uncelebrated, I hope you feel celebrated by my voice. Home health agencies have experienced massive financial shortages, just like acute care facilities, due to the elimination of elective surgeries. You know, we received all of those patients, many of those patients, after their elective surgeries. And when hospitals ceased to provide those, that business dried up for us too. That resulted in decreased admissions, increased expenses for supplies to protect our patients and employees, and we have experienced furloughs and layoffs as well. Speaking of that, the fears among those with which I work have been furloughs, layoffs, bringing illnesses home to their families, and access to personal protective equipment. If I could leave you with something, it is that telehealth has proven to be an important tool in caring for people in their homes. At first, when we started talking about this in our agencies, people would say, gosh, you know, our older patients are never going to be able to do this. You know, I had to smile to myself, because many times people said, you know, our older patients are not going to be able to learn how to connect electronically. They don't have access to a laptop or a desktop computer. Most of my patients had phones, and they were on Facebook because they wanted to keep up with their family members. And now, although not all, many people have been keeping connected to their families using technology. And we can turn that around and use this acceptance of technology to our advantage in home care. Thank you for allowing me this opportunity to spend a short time with you talking about something big that has happened in home care, which is PDGM. And if you have any questions, I hope that you will enter them into the chat. We have a live question and answer period at a little later in the program. And in the meantime, you can certainly write to me at my email address, which is up on the screen now. Again, thank you for joining me today. It's certainly been my pleasure to speak with you, and I look forward to seeing you again soon.